Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and today we are talking all about migraines and headaches. For Oh My Aching Head, I have Frances West here with me from Center for Neurosciences. She works actually at TMC as well, and she is a nurse practitioner. She has been with our stroke program for several years. And so I'm so glad you were able to be here today, Fran. Thank you. Thanks for being here.
Very welcome. Good afternoon, everybody. And I understand I have some actual people in front of me, and then, of course, the virtual audience. So I will try to remember that I'm speaking to people not present and not walk off the screen, but I might forget. So headache, I'll tell you, and if it looks like I'm not looking at anyone, it's because I'm actually looking over my computer screen to the people who are in front of me, which is a little more natural, I think. Anyway, so headache is a broad topic, and I tried to get it to kind of cone down a little bit because really what are the things we want to focus on? So I was told we want to look at migraine headaches, we want to look at tension headaches, which are very common, and then when should you be worried about a headache? From a neurology perspective, when are headaches worrisome? So, headache is a common problem, very common problem. And in this country, I would say migraine headache is one of the three top disabling disorders that people have. So, not insignificant from a health, as far as I know, nobody ever died from their migraine or anything. There are certain things about headaches, though, that are worrisome, not so much because of mortality, because we think you're going to die, but because it has such an adverse effect on the quality of life. All right, so most headaches fall into one of three categories. Oops, sorry about that. Migraine, tension type headaches, and cluster headaches. These are primary headache disorders, so that means that they're not caused by some other underlying problem. You can get headaches for all kinds of reasons. If you have a viral infection, who ever had anything from the common cold to COVID, you will have a headache. Women, and when they come into the emergency department with horrible, horrible headaches, I'm like, check a urine because UTI, common reason that gives women headaches. If you are somebody who's prone to headache, anytime you have something else going on, it'll probably be a trigger for your headaches, and they'll probably be a little bit worse in intensity until you treat the underlying problem. But migraine itself is a primary headache disorder. It is the problem, and that's what we're treating. It's not caused by something else, and that again is true for these others. Um, so just some, little factoids to take home to just kind of grasp the scale of the problem. Worldwide, 1 in 7 people suffer from migraines. 28 million women, it's probably more now. I try to keep up with the statistics, but they do get updated. But at least 28 million women in the US have migraines. Now, that does not mean men don't suffer from them. An interesting migraine fact is that before puberty, it's more common in males. After puberty, it's more common in females, probably by a ratio of 2 to 3 to 1. It's pretty significant. As with like autoimmune disease, doesn't mean men don't get it, just more common in women for the most part. Acute attack by definition, so a migraine attack is anywhere from about 4 to 72 hours. If you have symptoms that last more than 72 hours, particularly despite treatment, you're considered status migrainosus, is what it's called. So that's sustained refractory headache. You're doing all your usual stuff, it's not going away. And those are often the people who show up in the ERs that we have to admit for more aggressive inpatient management. But that's not really the scope of our talk today, but just so you know that. So neurologic symptoms are present in about 20% of people who have migraines. It's not across the board. And by neurologic symptoms, I mean changes in sensation. They might have weakness, they might have speech issues. So it can be a variety of things. And again, this makes it a little challenging on the people in ER because you come walking through the door with this horrible headache and then complaining of symptoms on one side of your body, they're going to treat you as a stroke until proven otherwise, basically. Let's see. And then again, about a fifth of the people who have chronic migraines actually are disabled by them. They find it difficult to lead a normal life, and that includes things like work. You know, so costly. It's a societally it is a costly disorder, and migraine sufferers, not surprisingly, have other disorders, and a sleep disorder is a big part of it. And it's kind of a catch-22 because if you have poor sleep, if you have some underlying sleep disorder like sleep apnea, for example, that can be a trigger for your migraines. And then, of course, once you have migraines and you have pain, it disrupts your sleep cycle and it just gets to be a big, vicious downward spiral. All right. So I thought this was rather interesting. I'm sort of like, is that really true? Because I feel like in any outpatient neurology practice, we see a lot of migraine. I mean, I did that for a couple of years before I came back to the hospital, and we saw a lot of migraineurs, but roughly 95% of them apparently don't actually seek treatment. They're just like, well, I have migraines and I just have to live with it. Or my mother had migraines, so it's not really a surprise I have migraines, and it is what it is. But yet, with the 5% of people that present, and I do kind of question that. I may have to look at that statistic a little more closely. But we spend as a society, and I'm just talking about the US, upwards of about $1 billion a year imaging these people with headache disorders. Specifically, almost always it's migraine related. $1 billion. But we actually spend closer to 17 billion on migraines, and that's management, and that means treating them, the medications, the workup, getting the diagnosis, whether they have ongoing management that also includes the medications, which are not cheap. A lot of the things that we use to treat migraines are expensive, so you have to play the prior authorization game if you're on our side of the equation, and then managing side effects of medications as well. Sometimes the medications that we're using to treat them are not the most benign things either. And then indirect costs, as we kind of discussed a little bit earlier, really think about lost productivity. Everybody here is either has, a migrainer, which is kind of the term we use for them, or knows people who are. And think about how much lost life there is. Now, that's a bad way to put it. Lost productivity in terms of work missed, but also just in living your best life. How many times have you known somebody with a migraine that's stuck in a room for 2 or 3 days with the, shades pulled, the lights down, don't look at me, don't touch me, don't talk to me, they're nauseated, they can't handle just normal stimuli, sends them over the moon. So it's not something to be taken lightly. So once again, primary headache disorder. Now I'll tell you, if you ever go to any headache conference, they spend the whole first day talking about nomenclature. Like, what are we going to call it? I don't really care what you call it. And that shifts, that changes all the time, as long as we're talking about the same thing and we all understand what the definition is. So this is, we used to say, oh, they're like 8 main types or whatever. Right now, we're looking at about 7. Migraine without aura, and I sort of give you an idea of the breakdown. If you add up all those percentages, it's not 100. But there are people who have overlapping types. Just because you have one type of headache doesn't mean you don't have another. And that's even true in the context of migraine. People can have a mixed picture. They can have migraine with or without aura, or any of these other subclasses. Retinal migraines are what we used to call the ocular or ophthalmic migraines. And sometimes, and also bear in mind too, that with migraine, you don't always have pain. You might have the other symptomatology without ever getting a headache or a significant headache.
It took me years.
Right, I was going to say, diagnosis is a challenge for these folks. And then things like these abdominal migraines, where they have a lot of kind of GI symptoms and everything. But remember, it's a neurologic disorder, and we think a lot of it has to do with signaling and pain, abnormal pain signaling, and then the spreading of it. And that can include cranial nerves and brainstem. And one of the cranial nerves is 10, and 10 is the one that goes down and innervates your upper gut. So you can get things like nausea that has no real explanation, abdominal pain, etc. And that's a tricky one to diagnose as well. And it's almost always diagnosed by somebody who specializes in headache. So, and then, yeah, the silent migraine, once again, there's some overlap in this different terminology. When we talk about retinal migraines, I should point out what we're really talking about with those are people who will get unilateral, one eye, not the blurred vision, et cetera. It's usually, it can be decreased vision or actual vision loss, but it's going to be in the one eye, not both eyes. A lot of headache subtypes, including tension headaches, you'll get sort of that bilateral eye pain, maybe behind the eye, may get a little bit of blurred vision, difficulty focusing. And who's to say if that's really an eye problem or if it's really more distraction by pain. But if you have a retinal migraine, it's one eye with decreased or loss of vision without any damage to the retina for the most part. We don't really think that permanently affects the eye. Although never say never, because we do know there are instances where there might be a decreased blood flow to the retina that could lead to more, permanent vision changes. That's not typical though. So, we think migraines are a neurobiological disorder. We used to think it was a vascular disorder. It was a problem with the blood vessels of the brain and the scalp, but really those are involved. But the real problem is inside the brain. So as I tell people with all kinds of neurological disorders, if somebody is telling you that your symptoms, your pain is all in your brain, you agree with them because that is the truth. Even if you have some other type of chronic pain disorder, it's up here where the problem lies. You could have a structural thing that's driving your pain, but pain signaling and that tendency to go into chronic pain or to have pain in excess of the stimulus that you're getting, that's your neurochemistry going on too. And that's why we use so many different kinds of medications that on the top of it, you would sort of say, this is odd. Why am I taking an antidepressant for my chronic back pain? Well, it's because it works on your neurochemistry. And what we're trying to do is block pain signaling. So some of the other key things with migraine, sorry about that. So neurobiologically based, you have recurrent episodic headaches, and they do tend to be stereotypical. Most people have their migraines in a certain way. There might be a range that they go. Sometimes it's milder than others, but the onset, the characteristics are standardized, if you will, and stereotypical. It is characterized by nausea, although not always, and this photophobia and phonophobia. So there tends to be light sensitivity, sound sensitivity. Movement and activity make it worse. We think exercise is great as a prevention, but when you actually have a headache, that is not the time to go out and, run laps because it's not going to help. I think a key component to remember with migraines is they're unilateral. In other words, one side is affected. Now, it doesn't mean it can't migrate. It doesn't mean it can't change sides, but in general, it affects one side. And looking more at that vascular thing, because we used to think, all right, it's a problem with blood vessels being dilated. So a lot of the medications we use to treat it in the acute phase, so in other words, rescue medications, are vasoconstrictors, make things tighten up. And that does help. But that's not all of it, because then you would think, all right, if we get people right in the middle of their migraines and we do the vascular imaging, this is what we're going to find. And we don't find it. They don't really actually have vascular abnormalities, and their blood vessels don't behave abnormally. So there's more to it than that. And they're actually, I'll talk more about this too, they're phases of migraine. It goes through a process. So there is a genetic component. Anybody who has migraines probably has somebody else in the family has migraines. Dad, mom, sisters, brothers, whatever, aunts, uncles. There's usually almost always a genetic component. And what we think that really means is that you are just more susceptible. You are a person who is more likely to have headaches. And once that cycle starts, you are probably a little more prone to have pain or pain in excess of what somebody who doesn't have a chronic headache disorder has. Because most people have some kind of headache during the course of their lives, but that kind of thing is a totally separate entity than migraines, which is a chronic disease. And it's chronic in the way diabetes is chronic or high blood pressure or anything else. You learn to manage it, but most of the time it is not something that's just going to go away if you ignore it. Although certainly people can have remission, like they may go years without it and may not even need medication. It doesn't mean it can't come back. It can come back. With women, menopause seems to help. A lot of women will report a decrease in headache frequency or severity once they go through menopause, but there's no guarantee. We'll talk a little more about that too, the whole hormone thing. So, prodrome. A lot of people, and this is why we have people keep headache diaries, because you want to look for patterns. It's all about pattern recognition. And before the actual migraine occurs, and that's both with the aura and without, they usually don't feel too great, like in the like the previous day. May just feel a little bit off, can't really pinpoint why, but it's just not like their usual self. And it's usually some increased fatigue, just maybe generalized, maybe they have body aches or something like that, but they're not sick, they're not running fevers, but or maybe they feel like a little something coming on, like the head's a little sore, but it's not really their migraine. And then, so that's, maybe 24 hours ahead of time. Then you might get aura. And again, not everybody who has migraine has an aura, but an aura is, I think of it like epilepsy. If you have focal onset seizures, which is the most common type of epilepsy, you can start with just a little disruption in the usual patterns. And it just starts in a little teeny area like the size of like your pinky nail, and then it can spread. And the reason we give people medication is to prevent that spread so that it doesn't go on to become a bigger thing. Well, the same kind of thing can happen with migraines. You start with a little area that's irritated, that's a little bit hyperactive, and then it starts to spread. The signaling spreads. This is where the neurotransmitters come in, and you can get like this cortical depression, where that it blocks other stuff, and then the abnormal signaling takes over. And then it'll aggravate the trigeminal nerve, which is the cranial nerve 5, and that's a big sensory nerve with branches. And once that gets activated, it's a lot harder to manage. So, again, our goal is to kind of block that. But once you get, an aura, so is kind of the preliminary phase, and that can be, maybe few minutes to an hour or so before you actually get headache. And auras can come with the headache, frankly. They usually precede it, but they can occur together. Sometimes there's even a little bit of a delay, but it's considered a separate process. I mean, it sounds like you're splitting hairs, but the key there is that the aura is recognizable to people. They recognize their own pattern, but it's not really the headache itself. It's kind of the warning sign, like, oh, if I'm going to take something, I need to take it now, because the next thing that's going to happen is my headache's going to start. And that is also a key feature of management, is that when you notice that, and most people who have migraines recognize the difference between like, this is going to be a pretty mild one, it's no big deal, to, oh, this is going to be one of my bad ones. You got to get on it early. It responds to treatment much better if you do it early on. Because like with everything else in life, once it's established, it's a lot harder to kick out. After migraine, you'll often get what we refer to as a migraine hangover. There's not really a true horrible pounding headache anymore, but there's just kind of this dull kind of after ache that you get, and people just feel very fatigued, and even some scalp tenderness. They'll be like, oh yeah, my head feels kind of sore, but the main headache has passed. So, then it might take a day or two for you to feel back to normal again. So imagine if this happens to you 15 times in a month, or, and that is kind of the definition, more or less in 15 days a month is kind of how we divide up the migrators as far as how we're going to manage them, whether they do rescue meds or whether they really need to be on preventative treatment. And, that 15 days a month, well, what if you get a headache and it lasts for 5 days and that happens to you 3 times in a month? That's probably somebody I would put on prevention rather than rescue medication. So we've talked about that predisposition, that vulnerability to having the headaches. You activate the trigeminal nerve, and again, trigeminal means it's got 3 branches, and they basically go like this. And it's one of the brainstem cranial nerves, exits out back this way, this is the occipital, comes this way, comes around. But once it exits out there, it becomes part of the headache process. Once that those neurotransmitters, the excitatory ones, the things that ramp things up, once they activate that trigeminal nerve, it is very good at transmitting pain. Now, are you all familiar with trigeminal neuralgia, with that condition? That's also a condition of that trigeminal nerve. And we actually manage it most of the time with an epilepsy medication. We use carbamazepine, which is Tegretol. So, so the pain modulation, which is what I was alluding to before, pain is really a big part of having pain, and pain that persists or lasts longer than it should, given what the problem is. That means you're upregulated. You've got excitatory neurotransmitters kind of taken over in your brain, and they are firing and they're overfiring, and they're telling two friends and they're telling two friends, and now you've got more pain receptors on your neurons and your axons, and so the whole system is upregulated. So medication, the idea is, one of the things we're trying to accomplish with that is to bring it all down. Nobody should ever promise you're going to be pain-free or you won't ever have a headache again or anything else. The goal of care, of treatment, is to decrease the frequency and decrease the severity of your episodes. Because realistically, you can't ever promise somebody we're going to take it all away. So like I said, it's a chronic problem. So new things that we're seeing in neurology is this whole neuroimmunology and things like that, and not just related to migraine, related to a whole lot of other things. But we have found that there's a connection to people with these chronic headache disorders, especially like migraines. We think they might have what they call channelopathies. So, you have channels in the brain and elsewhere in the body where ions are exchanged. There's sodium potassium pumps, there are calcium channels, and if you look at blood pressure medications, you're like, oh, okay, yeah. Well, the same thing happens up here too. And if there are genetic predispositions where you don't make enough of it, you don't have enough receptor sites. There are a number of ways the process can go wrong, but we think that there is a correlation between those kind of things, which frankly, we're not even quite sure how we test for. And some of it's been found out by accident by looking at other issues, but we think that probably plays a role in at least some percentage of the people that have this problem. Okay. So we talked about cortical spread, which again, everything's ramping up, and then it starts taking over. Starts small, takes over, and spreads. And that is that activation process. So how you approach treating this is, part of it is deciding where in that process am I going to try and interrupt the cycle. So we'll talk a little bit about, and then there's a difference between acute management and long-term prevention. This hyperemia, getting back to the blood flow issue, is early on you can get excess flow, right? You get that area gets congested. And we always thought, well, that's the process, right? It gets congested, there's extra blood flow in there, that's being a trigger, there's pressure on the nerves around it, etc. But interestingly, that's followed by a relative vasoconstriction, where you have decreased blood flow and everything. And then they've done things like functional MRIs to look at this. And unlike our previous thoughts on it, it turns out that the actual headache pain seems to happen during the process when there's less blood flow. So did it all get triggered by the increased blood flow and the pressure? And then as that part, wanes, that would be waning, going down. As that wanes, is it really the decreased blood flow that triggers the headache? Probably not. Again, it's probably kind of the pendulum swung the other way, but the process was already started, and that's why the headache is present, even though it's not probably directly related to that decreased blood flow. And that's probably why those vasoconstricted drugs like triptans, like DHE, et cetera, that's probably why they work in the acute phase. So migraine triggers, oh boy. Everybody has their migraine in their own way. Even if you have the same type of migraine, you have your own triggers, and this is also where headache diaries come in handy. What are your triggers? There are obvious ones, stress, and nobody lives a stress-free life, but certainly we all have times when stress is worse. And what goes on with stress? Often you have poor sleep when you're stressed out, right? That in itself can do it. That can be physical stress as well as mental stress, because if you are sick with something else, what if you have an infection, what if you broke your leg, what if you just had to travel halfway around the world, that's going to make you more likely to have a headache. I have a friend who, if she drove at night and oncoming lights hit her in the face, that was a trigger for her migraines. So the key thing is recognizing what your own triggers are, because physical exertion, and that's a tough one too, because truthfully, regular exercise and things that's important for migraine prevention. But once again, if you're actually actively having a headache, that's going to make it worse. If you go out and you've been a couch potato for 10 years and you decide you're going to run a 5K, that will probably trigger your migraine, because you got to work up to stuff like that. You can't go 0 to 60 and think it's not going to stress your body out and quite possibly trigger a migraine. Talked about fatigue, lack of sleep, hunger. Some people, if their sugar gets a little low, although, you could argue, well, that's a headache because you have low blood sugar. But if you're a migrainer and that process starts, that could be a trigger for the migraine as well, right? Because that's a stress on your body. Odors, chemicals. I actually cannot stand walking by perfume counters, because that's like instant headache for me. I can't deal with that. Chemicals of any sort. Bleach, household cleaners can be a problem for people. Not everyone has this, but these are well-known triggers. Medications. Certain medications are known to cause headaches, including some of the ones that we use to treat other pain conditions, like tricyclic antidepressants, dry mouth and headache. And if you look at the insert for any medication, it will make you just decide you're not going to take anything at all, because it's like 5 pages long. And, I think Jeff Foxworthy has a good routine on that. And then low estrogen. And so in women, it's called a catamenial headache or a catamenial migraine. And that was a class unto itself. And we used to think, okay, so if the estrogen drops down right before they start their cycle and they get migraines, we'll put them all on, combined oral contraceptives, and that'll take care of it. Well, clearly it's not that simple, because it didn't. But there are women who very definitely have cycle-related patterns, and that's probably the population that's most likely to benefit from menopause. Okay, now multimodal treatment, right? So medication is not the end-all and be-all. It's going to help, and that's what medication should do. That should improve your quality of life. Otherwise, why you take them and deal with the potential side effects. Diet and exercise, and so part of that is also recognizing your trigger. I didn't really address that in the previous slide, but there are food triggers. Some people have very definite food triggers, and it's not like everybody who has MSG has migraines or vice versa. But, red wine can be a problem, chocolate can be a problem. You have to know yourself and know your patterns and figure out what and it's kind of like having food allergies. It's not the easiest thing to always recognize. You sort of have to cone it down, eliminate a whole lot of stuff, be very basic, and as you add things in, you can figure out, is this my trigger? Is this a problem for me? Let's see. So acute treatment, which is, we call that, rescue medication. So somebody's starting to have a headache, they can tell their migraine's coming on, that's when you want to take the medicine, because that's when it's going to do you the most good. Now, has anybody here ever taken any of the triptans, like sumatriptan, rizatriptan, etc.? So those were like, when sumatriptan first came on the market, we were like, oh my gosh, this is like, and then we had to wait 20 more years for other stuff. So those, again, very potent vasoconstrictors, and there are a whole bunch of them in that class. And I'll talk a little bit more about them, but that's how they act on the body. They are potent vasoconstrictors. They tighten those blood vessels up. Tylenol, we actually like Tylenol. If that works for you, and it actually works for me, why not? Because that's probably got it's the medication least likely to cause you problems in terms of side effects or anything else. And aspirin, also effective, but we all know you're not supposed to be taking handfuls of aspirin, because you'll end up with either bad kidneys or an ulcer. So aspirin is a wonderful thing, but if it had been invented 50 years later, it would be a controlled substance. I mean, not controlled in the sense of like a narcotic, but it would probably be prescription. NSAIDs. So non-steroidal anti-inflammatory drugs are like actually one of the cornerstones of migraine management. And this is true particularly in children. Actually, that's one of their hallmark things they start with. So that's ibuprofen, that's naproxen. In heavy-duty migraines, like people with status, we might use indomethacin, which some nurses might be familiar with. People having a gouty flare, we use indomethacin. It's it's a strong one. But any of these will do. And they've come up with different formulations now where you can get the powdered one that you mix up. But most anti-inflammatories, non-steroidal anti-inflammatories, are effective. In kids, the first thing we do is give them some ibuprofen, tell them to drink some Powerade so they get the electrolytes, right, and go lay down. That really actually works well in adults too, in the sense of many people are a little dehydrated when they have their headaches, so it's never a bad idea to give them fluids, or if you can get fluids down. Of course, the tricky part is if they're already in the phase where they've got nausea, I guess what they don't want, and I would definitely not suck down a bunch of water because water can trigger nausea. So ginger ale, 7-Up, whatever. Now, combination medications. So the old, what was it called? Is it Duragesic? What the heck? Because I can't remember. We used to have like an aspirin caffeine combo, and now there's a Tylenol caffeine butalbital combination, which is Fioricet. Interestingly enough, I don't think that's happened here yet, but the European Headache Society has taken it off their list of recommended rescue medications. They think that there's a high risk for kind of rebound headache and dependency for that particular medication. And it's really, when they do head-to-head studies and everything, it's not really that efficacious. So I think the thing to remember about some of these things, mild to moderate headaches, right at the beginning. This is not for the severe person who's, it's early on in the process when it's still mild, at most moderate. One of the take-homes from this is that even over-the-counter medication, so Tylenol, ibuprofen, naproxen, can cause rebound headache, can cause a chronic daily headache, which is really a medication overuse headache if you use it more than twice a week. So I would always tell people, think of it like somebody with asthma. If you have to use your albuterol inhaler more than twice a week, you are not well managed on your asthma. The same thing is really true for the headaches, for the migraines. If you have to use Tylenol, ibuprofen, whatever, more than twice a week, you're not well managed. You probably do need to be on some kind of daily prevention for your headaches, because you can, even with these over-the-counter things, develop that tolerance. And if you don't take it, you'll get a worse headache. That's what a rebound headache is. If you don't take the stuff your brain is used to getting, it will let you know, and it won't be subtle about it. You'll get a nasty headache. These chronic daily headaches, we think many, many times are really medication overuse headaches. And once again, that brain has gotten used to it, and if you vary that regimen at all, you'll get a nasty headache. And so for some of these people, when they do present to neurology clinic with, years of headaches and on 80 gazillion things from 12 different providers, the first thing you have to do is get them off all that stuff so you know what you're dealing with. You actually have to have some idea of, all right, what does your headache really look like under all this stuff, and what are your patterns, et cetera. So you take everything off and you start from scratch, which is a miserable thing to have to tell people. Yeah, guess what I'm going to do? I'm going to take away all your crutches. And it sounds really mean, but truly, you really have to go back to the chicken, or maybe egg. Maybe that's the egg. I don't know. All right. So, and also things like ibuprofen, and even aspirin, frankly, you're not going to give that to people who have chronic kidney disease. You are not going to give that to people who have a history of ulcers, gastritis, etc. And really, I don't know, aspirin especially is just not, as wonderful a drug as it is, it's not meant to be taken all the time, and that's true for most of them. So we talked about the triptans. I've given you all of them in there, and there are a bunch of them. The takeaway from that is if you don't do well on one triptan, it used to be, when sumatriptan came out, the very first one, it was an injectable. I'll tell you what, it works very well as an injectable, but of course people were kind of like, do I have to? So when they came out with the pill form, everybody was like, yay. But it is effective. But if that one doesn't work, one of the other ones might. Just because you don't tolerate one of them doesn't mean you can't tolerate one of the others. And they do vary a little bit. Some of them are much more short acting than others, others are more moderate. And I'm talking about sort of relative time of onset and how long it lasts. So it's actually a very good class of drugs to manage migraines for a rescue medication. The key thing is you got to take it early in the game. At most, you can repeat it once. Like if you don't have an effect, you can repeat it in about 2 hours. And not with all of them, with most of them you can. And if that doesn't do it, then you got to, pick a different plan, basically. And most people who have, like with asthma, people who have these issues really should have treatment plan. Like, all right, if this is what's going on, we're going with A. If that doesn't work, we're going to go with B. And then, you have a backup plan, if not several of them. People who have heart disease should not take triptans because patent vasoconstrictor can give you, even if you don't have heart problems, the side effects can be chest pain, can be shortness of breath. You can develop vision changes. It tends to be transient, but for some people, these are intolerable side effects. I don't know that, palpitations and things, you're already feeling bad, and now you're going to have an anxiety attack on top of everything else. So they don't work for everyone, but like I said, it's worth trying other agents in that class if one of them doesn't work well. If you're over 50, as a rule, and headache specialists will be a little bit broader about it. The rule of thumb that we're all taught is that if a person's over 50, that probably is not going to be your first go-to drug because, again, even if they've never been diagnosed with vascular disease, heart problems, whatever, if you're over 50, chances are, you might have something like that. Or you might be somebody who's, if we give you a triptan, all of a sudden you go into AFib, that's not helping. So we're more cautious. It doesn't mean people over 50 can't have it. And if they've been on it, we're not going to say, oh, you're 50 in 1 day, so now you have to stop your triptan. No, not unless there's a clinical reason to do so. But we would hesitate probably to start somebody on that, if they were over 50 when they got diagnosed. Okay. Antinausea medications. So that can be Reglan, that can be Compazine, that can be Phenergan, which is promethazine. In neurology, we have kind of a love-hate relationship with things like all of those because they can cause like extrapyramidal symptoms. They can cause neurologic side effects. But there is data that if you are a migrainer and you're having an attack, that Phenergan, which is the promethazine, is actually helpful. That is a helpful one. So what you often get if you're in a neurology office or you're in the ED and they're trying to give you a cocktail, it's usually a combination of Toradol, ketorolac, which is an anti-inflammatory, and one of these antiemetics or anti-nausea medications, the metoclopramide, the chlorpromazine, and that's the Compazine, or the prochlorperazine, which is Phenergan, which is a lot easier to say. So you're going to usually get that. I put diphenhydramine in there because we give people the Benadryl, that's what diphenhydramine is, because it will counteract the extrapyramidal symptoms that you might get from the others. So that's why you get that particular combination. Lasmiditan, which is this Reval, I personally have no experience using this medication at all. It's out there. It is a 5-HT, selective 5-HT like receptor agonist. So that actually puts it in the same category, not the same category chemically, but, and again, it's selective, not broad spectrum. It targets a very specific receptor, but things like the benzodiazepines also work on those receptors, but they're, broader. So it can help block the pain signaling, but it can also cause drowsiness, as can most of these other things. That's a side effect of a lot of them is drowsiness. So you don't take this stuff and go driving. That would be the take home there. And it's good for people who can't tolerate the triptans. Also, one of those prior auth things that you've had good luck trying to get it. Because, and I have a good friend who's a headache specialist, and I'll have to ask her if she's really actually got anybody on this, because she and I never talk about this particular drug. And drug usage can sometimes be local, and regional. But I'll ask her if she's got any patients on this one. It's certainly not something we're using in-house. We don't use it in the ED or anything. So the big thing that hit migraine, which like I said, we went 20 some odd years, I think, without having anything new, were these CGRPs. And I call them the CGRP eyes because the key thing to remember, it stands for calcitonin gene related peptide, but it's an inhibitor. And this is another one of the things they found out by accident because they were studying something completely different. But it can treat several different migraine types, and it blocks pain signaling from that trigeminal nerve. That is how it works. In the rest of the body, it's pro-inflammatory, right? So this is why you want to block it, because you don't really want an inflammatory. But in the rest of the body, that process is the beginning of repair, like so wound repair and things like that. So it has useful properties, but in the head, it seems to be it's just the opposite. It just triggers a cascade of pain signaling, essentially. And so these new drugs that have come out are specifically targeting those receptor sites and blocking them. And they're very effective. They have been very effective medications. And they don't seem to have significant side effects. And I think you can offer them to a broader range of people, who may have, again, maybe they have high blood pressure, maybe they have heart disease, maybe they've had strokes, and we really don't want to give them triptans. There are two different types in this category, and I'll tell you, I do not give these at all. I am aware of them. I've done the basic education, looked them up so that I know what they are when people come in the hospital. We don't give them in the hospital, and they are rescue medications. So when I'm seeing people, they are in status migrainosus. So we've already passed this stage, and that's why they're not really used in an inpatient setting. This is for folks out in clinic, and so the vast majority of people aren't managed in the hospital. So I should probably put that caveat in here. I'll tell you about them, but I am not the person that does that. So, and I gave you all the names of the ones that are on the market in this country. The ones I'm most familiar with are Amavig. That was the first one that hit here, the Ajovy and the Emgality. And then I'm seeing patients who do the Ubrelvy as well. And sometimes they'll be on a combination too, because you can sort of thinking of it as doing like a short acting and a long acting. But from what I understand in the outpatient clinic, that just gives you a whole lot of headaches dealing with the insurance company. But, so, I mean, for a time, they weren't even letting people, if you were already on Botox, you wouldn't get these. They wouldn't approve both. I think that has been improving since they've been out a couple of years. But, or a few years now, but that, it's just a natural, I guess that's just the way things go, basically, when new things come out. When you see the ODT there, that means dissolving, so these are the dissolving ones. You put it under the tongue, or dissolving tablet. So there are pill form, the Rimegapant, the Ubrogapant, and the Atogapant, which I have not actually seen locally. Those are all oral, so it's either going to be a pill or one of those dissolving things. The rest of them are injectables, and that can be anything from once or twice a week to once a month. So it just depends on which one you're on. Ergots or ergotamine. So I think these are all derived from fungi. Remember all the mass hallucinations in New England back in the witch hunt days? That's what they think that the ergotamines got into their rye, as opposed to actually having witches. So what those do, again, very potent vasoconstrictors. So when somebody comes in status migrainosus, and you can go into clinic and get this sometimes too, but they will monitor you. These are people that we want to put on at least a bedside monitor. We keep them on cardiac monitors. We watch the blood pressure and everything because, if triptans can do that, DHE is a whole heck of a lot stronger than a triptan. And we usually get a test dose of a lesser one, and we often pre-medicate these people because the most common side effect is that they vomit. They have instant nausea and vomiting, and then they're like, oh, I feel so much better, if it goes well. But we, don't want them to have to go through that, so we tend to pre-medicate. But it is just a very potent vasoconstrictor. Dexamethasone is a type of steroid. The reason it's called dexamethasone, the dex is for 10, is about 10 times stronger than prednisone. But it's a good rescue medication. And if you're in an outpatient clinic, for example, and somebody's just having, like it's monsoon season and their headaches are horrible compared to normal, what I would used to do is put them on like 6 milligrams of dexamethasone, just take it once a day for 3 days and see if I could break the cycle, just as, again, kind of a rescue medication. And steroid in general can be very helpful. It's an anti-inflammatory, right? And people feel better on steroids as a rule. But you can't keep them on steroids forever, and you're not going to give them big honking doses. What if your patient has diabetes or something? But you could, in theory, even do something like a Medrol dose pack, just a graded dose over like 6 days, and that might help. So neuromodulation, there are different products out there, and there are some. I remember there was this one. It looked sort of like Wonder Woman. What was it called? Golly, I can't remember now. This is a few years ago, like 6, 7 years ago. It's probably still out there. And I think you put it on, and it gave like magnetic pulsations or something. And they can use ultrasound, sound waves, things like that. And there has been some success with that. But obviously, that's not your typical in-home kind of remedy. That's going to be done under some kind of monitoring. But it could be done in a clinic setting. You don't have to come in. We don't use it in the hospital. I can tell you that flat out. And I didn't see this on anybody's list anywhere, but caffeine. That's how many people get headaches from caffeine withdrawal, right? That alone. And that is one thing we tell our migraineurs. We're like, all right, we're not telling you can't have coffee or have tea or have Coke or whatever, but look at how much you're drinking. Because if we think you can get rebound headache or chronic daily headache, like medication overuse headache from too much Tylenol, what on earth is, 4 cups of caffeine doing to you? And then if you don't get that. So, I kicking and screaming will anyone take my coffee away from me, but I recognize that I will have terrible headaches if I don't get my morning coffee. Some of it may be psychological, but maybe not. The other thing is when people at time of onset of headache, it is very reasonable to say, go drink a Coke, go have a cup of coffee or something and see if that helps and if that's your rescue. And at the same time, for every cup of coffee that you're having, have some water too, because it's a diuretic, really. It's going to make you pee. So then if you're already a little dehydrated, it's going to aggravate that. So, I always say have both. If you're going to do that, then balance it out with actual water. Or again, if you have nausea, ginger ale, 7-Up, whatever. And we can give it IV. So we don't do it for migraines, but we do it for people who have positional headaches. So maybe they have actually hypotension in their nervous system, meaning, they have some kind of like a spinal fluid leak. That does happen, that people who are diagnosed with migraines, we figure out sometimes years later that what they really have is chronic intracranial hypotension. And you treat that a lot differently. Not the least of which is probably a blood patch to try and plug the leak wherever it may be. Because often I've seen those cases where they go in and they try to do like a myelogram or something and figure out where that leak is, put a tracer in or something. You can't always find it, but you look at the imaging and you can see their little cerebellar tonsils are kind of sagging down, and they have this classic story of I'm fine as long as I'm laying. And as soon as I sit up or stand up, I get this horrible headache. So, that is somebody I would think about as maybe the problem is really that you have chronic intracranial hypotension, it's low pressure. Caffeine helps those folks, so if we have spinal headaches, post-lumbar puncture or something, we're always like, drink as much caffeine as you want. And we will give it IV if it's persistent. All right, so prevention, diet and lifestyle, recognizing your triggers, but in general, just eating a healthier diet and try to cut back on if not eliminate the processed foods. That's a big one, and that's anything, it's too much salt, it's too much sugar, and in general, too much, too many calories. But the big one is just all that stuff that's chemical that your body doesn't really need, and some people respond badly to. Beta blockers. Okay, the tried and true. This is where propranolol is one of the mainstays of migraine management as a prevention. Yes, it is a blood pressure medicine. It's one old beta blocker, so it's not very selective. You're not going to be giving it to somebody who has asthma or COPD or something like that. We try to stay away from starting young people on it because, if you're 20 years old, you really want something that's going to keep your heart rate at 60, so you have to take those kind of things into consideration when you're deciding what you're going to start people on. And some people tolerate it extremely well. Metoprolol can be used, and it's more selective, and so it tends to have fewer side effects, etc. I don't think it's as effective. Timolol, I personally have never seen used, except for eye drops for glaucoma. But That's what the data tells me, is that they do use that. But locally, I've never seen that used for prevention. But again, bearing in mind, not a headache specialist in the outpatient setting. Antidepressants. So the common ones are the tricyclic antidepressants, amitriptyline, nortriptyline, doxepin. So when you see people on that, don't always assume they're on it because they have depression. They might have depression because they have chronic pain, but they might have a chronic pain condition, and that could include migraine. The most common one is amitriptyline. If you look at the data, like statistically, I've always liked nortriptyline a little better. That's usually what I start with because I think it has fewer side effects. Biggest side effect that drives people nuts, dry mouth. Dry mouth, dry mouth, dry mouth. Nothing you can do about it. That's just the way it is. And I guess that encourages you to drink more water at any rate. You can have things like palpitations, the weight gain, but when we're managing it for migraine, we tend to go with lower doses. We certainly start lower, and we tend to put our kind of maintenance dose is generally lower than what they use for depression management. So I think that probably helps manage the side effects as well. Urinary retention is a very unpleasant side effect. I don't think I personally have had somebody with that, but it can happen, and it's usually dose related. Anti-seizure medications. Well, we used to call them the AEDs, the anti-epilepsy drugs. Remember what I said? And they're always changing names and stuff like that. Now they're ASMs. So gabapentin, topiramate, valproate. Topiramate is actually one of the mainstays of migraine prevention and management. That's Topamax, the old Topamax. Also fondly known as Dopamax, because it does have what we call psychomotor slowing. It kind of give you a little bit of brain fog. And sometimes, we use that as a behavioral management in certain populations too. But the good news is when you're taking it for migraines, we give it to you at nighttime. So if it makes you a little drowsy or anything, who cares? You're going to bed. But that is something to bear in mind. And once again, our doses are way lower than you would manage with epilepsy. Epilepsy has to be given twice a day, and the target range is a lot higher. Usually we give, start with like 25 milligrams a night. That's the smallest pill you can get. And then we increase it maybe 25 milligrams a week. It's a slow titration. The target's usually 100 to 200 milligrams at night. Going much higher than that, you sort of have to ask, is this really the right agent for you, or do we need to add on something different? The key thing to remember about topiramate is not good for people with a history of kidney stones, because it's a carbonic anhydrase inhibitor is what it's called, and there's another epilepsy medication called zonisamide, which sometimes can be substituted for topiramate too. Probably a little less effective, but better tolerated. And if you have somebody who's predisposed to kidney stones, that's not the medication you want to put them on. But even if they don't have any history of that, you always tell them you've got to stay hydrated. Water, water, water when you're taking that medication. And of course, you're not going to get it to somebody who's going to have children, right? People taking these medications for epilepsy, we still think it's safer to be on it because seizures are very bad for moms and babies too. But, if you've got a female of childbearing age that doesn't need it for seizure management, that's probably not the best medication to start her on, or you have to get her. Now, this is me. I don't think anybody else goes quite this far, but I'm like, you sign this contract that says you're on birth control or you have no uterus or something. Topiramate's probably not the worst, but it is associated with cleft palate. The one it is the worst that you never, ever, ever, ever. I don't even want to hear people talk about, I don't even want to hear the word pregnant around Depakote, which is what valproate is, because that is absolutely very high risk for abnormalities, developmental abnormalities. I mean, babies will be born with sections of brain that don't develop and things like that. Yeah, it's bad. So, female of childbearing age, I probably wouldn't go with that, period. Even if she swore up and down that she never ever even thought about having sex, would probably put her on valproate. Gabapentin, same thing, there is an increased risk of birth defects when you take these medications. So if you don't have epilepsy and you have migraines, this is not going to be my go-to. It can be used, it's not going to be my first choice. But gabapentin is the old Neurontin. And by extension, pregabalin, which is Lyrica, can also be used. GABA is an excitatory neurotransmitter in the brain, ramps things up. So obviously if you're taking gabapentin or you're taking Lyrica, what that does is calm those pathways down. And so that's why we think it helps with chronic pain management, and that includes migraines. But I would point out that the anti-seizure medications are not anybody's choice. They're not the first line. These might be added on, secondary or third line agents, if you're just having a hard time finding something that will keep this under control. And I think with these newer medicines, we'll probably be seeing less of it. And also, is this somebody who has, people with migraines don't exist in a bubble. They may have other conditions. And if they have other chronic pain issues, then you might see more of these agents used with them, because you're also trying to cover the other, neuropathy, whatever that they've got. But the TCAs are a primary treatment for headache. That is one of our go-tos, as with the beta blockers. So the two oldies but goodies are the propranolol, the beta blocker, and then verapamil, which is an old school calcium channel blocker. Now, calcium channel blockers, I've always wondered why this is. They're two different classes. They're what they call the DHPs, the dihydropyridines, and then the non-DHPs. And the non-DHPs include verapamil and nifedipine, which is the old Procardia. And that means that they have more effect on both heart rate and blood pressure. The non-DHPs are things like amlodipine, Norvasc, and apparently, for whatever reason, and I've had this discussion with people a few times, interestingly enough, the non-DHPs, like the amlodipines, how many people out there are on Norvasc for their blood pressure, right, or a related one? That doesn't seem to help with migraines. You got to go to the other ones, the older ones, the verapamil, the nifedipine. But once again, if you're looking at a younger person, or like an athlete who maybe during sleep their heart rate goes down in the 30s or 40s, do you really want to put them on one of these? They may end up with a pacemaker. So you have to consider the whole person, but they can be quite effective. And there are extended release formulations of these that also can kind of help minimize those side effects, what we would consider side effects, because we're not trying to treat their blood pressure, we're not trying to treat their heart rate with these, we're just trying to treat their headaches, but they can be effective. And I think it's because with the calcium channel blocker, you will get a vasodilatory effect, which sounds counterintuitive. If I'm giving them vasoconstrictors for their acute migraine, why am I putting them on something that dilates their blood vessels for prevention? So what that tells you is we don't really understand it that well yet. We're getting better, but we don't have a unifying theory of everything yet. So Botox, botulinum toxin A, that was another great breakthrough in management of migraine, right? So this is something that we've known for a long time. It's used in a lot of different areas for spasticity. So dystonias in neurology, where people have horrible spasmodic and contractures and things like that. Used it very successfully on people with cerebral palsy, for example, who as they get older get more spasticity, which gives them pain and reduced, range of motion, reduced movement and quality of life. You can Botox and kind of paralyze those muscles. And that's what it is. It's temporary paralysis of muscles. They can inject it straight through into the bladder, and can help some of the bladder spasticity issues like overactive bladder. So there are a lot of uses for it. In headache, they did a lot of research on it. It has turned out to be a wonderful preventative. It is, again, it's a temporary muscle paralysis. So by insurance, people will tell you they start having a wearing off effect after about day 80, like rate 84, 85, 86, and they can tell that they're due, but the insurance will not let you give the next dose until day 91. I mean, that's how it was, at least when I was an outpatient. But you can't just inject where the people have their migraines. Remember, most migraines are unilateral, but you don't go over there and say, okay, you always get it, in this right parietal area, or you get it frontal or whatever, we're just going to do that. Because the nature of the headache is such that it will just move. So they get a ring around the rosy, and there are very specific muscle groups that we target. It goes all the way around this way and then down into the neck as well. So it's like, I'm trying to remember, is it 150 units? Well, anyway, and it can be modified over time with, but most of the time people have very significant improvement in their headache symptoms. It doesn't always happen right away. That can be very individual, but what we say is when we get that, if you're going to do Botox, the agreement is you got to stick with it. You have to do at least 4 treatments. So that's a year of commitment, because you may not notice a great improvement after the first or even the second, but statistically speaking, the longer you're on it, the more effective it is over time. And it does not mean they go off all their other medications, but what we hope is that once this is established and they start having a response and it's sustained, that we can go down on their medications and maybe even eliminate some of them, and that they will have less need for the rescue medications. So that's the thought behind it. So herbal therapies. Now, we used to hand out samples back in the day. We had butterbur because they were looking at that and they thought this might have some effectiveness. And and feverfew is the other one. There have been more studies on feverfew, but none of them, because again, these are not regulated things, so it's hard to know, the dosage, the purity, et cetera. You can't really compare one manufacturer to another. So given that we just don't really have hard data, nobody really recommends them, but they can be tried. Magnesium is wonderful. As long as you don't have myasthenia gravis. So it is a membrane stabilizer. So it slows down transmission across the cell membrane, and that includes neuronal cells, that includes nerves. And so think about all the wonderful uses, right? We use magnesium for preterm labor, right? We use magnesium for cardiac rhythm problems, and it works great for migraines. And you can use it both as a rescue medication and as a prevention. And the worst side effect you're going to get from magnesium, especially, and it's really usually at higher doses, which we mostly don't prescribe, and not in neurology anyway, is it gives you loose stools. So, it's over the counter, you can get it in there. We usually tell people take 400 to 800 milligrams, so that's magnesium oxide. 400 to 800 milligrams, so that's 1 to 2 pills. You can take that twice a day. You can take it all at one time. You can take it every day. You can take it if you have a headache. Now, I think if you're starting to get up at like around 1,200 milligrams or something, you probably will have those side effects. But a little tidbit within, and I know a neurologist locally, this is what he does. There is a formulation called L-threonine that you can get on Amazon that if you don't tolerate the mag oxide, if it gives you like GI side effects, you take that stuff and it works very well. So, and I can also help people who just sort of have muscle aches and things. So, worth a try if you haven't tried it. And I will say when we do a migraine cocktail, then not necessarily the ED, but when we're doing it in neurology, we add magnesium sulfate. We hang IV, usually give them 1, if not 2 grams. Not repeatedly, but we'll give them an initial dose. So like magnesium. All right, tension headaches. I was asked to speak a little bit about tension headaches because they are common. They're not well understood, frankly, but as I just pointed out, we don't have a great handle on migraines either. So dull aching head pain, overlapping symptoms sometimes with migraine. You might get that throbbing pain. Eyes can be involved, things like blurred vision, but it's usually either here or in a band around like pressure like type. So once again, there's no cosmic rule that says you only have one kind of headache. And many people, when they describe their headaches, will have features of both. So it's really difficult to say sometimes if you have, migraine, or do you have tension, or probably you have both. You can definitely have both and features of both. Definitely at the onset, not so much as part of the after headache hangover, like you get migraines right from the start. You have scalp tenderness, like these people, their head hurts, their neck hurts, it hurts going down into their shoulders. I mean, there's muscle involvement in this. And so that's why when we treat this, we will often use things like muscle relaxers. But, you always want to be careful with that, because those are sedating. When people taking, even cyclobenzaprine, which in the realm of muscle relaxers is pretty benign. Well, that can be sedating. You don't want people taking the stuff and going out and driving and taking their kids to school and things like that. But that can help. We think this is another one where non-pharmacologic, meaning no medication, not no medication, but not relying solely on medication can really help because, this is where, all right, what do you do during the day? Are you hunched over a computer all the time? You need to stand up and walk around once an hour. You need to do some range of motion in your neck, gentle range of motion. Do not ever let anybody do high-speed maneuvers on your neck. That's how you end up with vertebral artery dissections. That's another topic because I have seen it. And I would say backing up to migraine too, I think worth trying are alternative therapies like acupuncture. There's data out there to support it. You you go out in the community, you talk to people, there are many people out there who have been successfully managed with things like acupuncture, and for other kind of conditions, other chronic pain issues too. So it is worth a try, as opposed to trying to escalate on how much medication you take. I mean, never mind escalating your dose. A lot of people end up on multiple medications. So it is worth trying these other things. It's worth doing a course of physical therapy and seeing if there is something else that might be a trigger. Do you have cervicogenic headaches? Do you really actually have arthritis in your cervical spine or something like that? And that's what we're calling your tension headache, because that's a secondary headache. A tension headache is actually a primary headache, but diagnosis is always tricky with headaches because lots of things can give you similar symptoms, right? And so it's a little bit of an elimination game. It's like, it takes a while to figure it out sometimes. Okay, yeah, and I should have put it out in bolded, judicious use. Because this is allopathic medicine. This is what I'm trained in. This is what we practice in this country. And our response to most things is, let me start you on a medicine, and maybe we need to increase the dose. Maybe we need to add another medication. And, that can really kind of snowball. And then, unless you say something or something happens to you to trigger a response, in other words, you end up in the hospital for something, a lot of times people will just let it ride. Oh, you've been on that medication, you've been on it for 10 years? Okay, fine. I'm not going to rock the boat, but, I don't think we're really doing justice to people that way. And particularly when it comes to managing things like chronic pain issues. All right. So tension headache comes under this heading of TAC, which is this trigeminal autonomic cephalalgias. Try saying that 10 times fast, which is why we call them TAC headaches. So this is a category of headache, totally separate from migraine. Autonomic features means that you have, in the autonomic nervous system, remember, is you have the sympathetic, the parasympathetic. The autonomic is the stuff, think of it as automatic, things that you don't consciously control. Heart rate, blood pressure, gastric motility, etc. So when you have autonomic symptoms with a headache, that's going to include things like tearing. You might have excessive tearing in one eye. That eye might get really bloodshot and injected. You might have, usually with the tearing goes a runny nose too, but really only on that one side. It's the oddest phenomenon. And that can sometimes even affect things like a pupillary response. And they are nasty because that can also include things like cluster headaches, what they call the suicide headaches, where people have intense pain, just lasts seconds, but it can happen like 100 times in an hour, right? And that would make you want to stab yourself in the eye with an ice pick. So they are not common compared to migraine disorders, but they're not pleasant either. And that can include things like hemicrania continua, which is basically, imagine just having a migraine, on one half of your head all the time. That's pretty much what that headache is. So nasty, not really within the scope of this talk, but it's recognizing that there are these other types of headache there. Some overlap with treatment. Again, our mainstays are things like the nonsteroidal anti-inflammatories. And these folks are often on other long-term management that could be, again, acupuncture, but biofeedback works very well for them because they are trying to rewire their brain, essentially. You want to disrupt this pain circuitry that's well established. And so that can include what, besides medication, what are the other ways I can change these neural pathways? All right. So I think the big thing I would take away from all this is one should be worried about your headache. So rapid onset of symptoms. Migraines tend to develop over time. Sometimes you're like, people may wake up with headaches, but often it's sort of like, oh, here it goes. And then there's a progression, but it's not like bits, you don't go from 0 to 60. There's a progression. Thunderclap headache, or what you would call the worst headache of my life. Like it's just a sudden onset, like just a bolt came out of the sky and hit you in the head, and now you have a horrible, horrible headache. Neurologic SIGs, that's supposed to be signs. My spell check didn't catch that. And so with that, that's going to be things that make you think stroke, right? All of a sudden you're talking funny. One side of your face feels numb. One side of your body feels numb. You feel weak, so anything that's a focal neurologic symptom. Or pain, pain of course is part of the headache thing as well. But stroke takes away things, right? It's a deficit. You can't do something, or you can't feel something, or you can't see something. But headaches, if you have those kind of neurologic signs, you absolutely need to come in, right? Because especially if that's new. Age of onset greater than 50. Most of the time you don't develop headache disorders after the age of 50. You've had them before. They may be getting a little worse, but if it's your usual pattern and everything, I'm less concerned than if all of a sudden you're like, I used to get one headache a year and now you're getting a headache every day. That needs to be evaluated. So headaches that get worse with position changes or valsalva. So valsalva is that bearing down, like you're gonna have a bowel movement. So that's increasing pressure. When you do that, that increases intracranial pressure, it increases intrathoracic pressure, and that's why they don't like heart patients to do it either and put themselves into ventricular tachycardia. Or actually, no, what they actually do is they braided themselves down. Their heart rate drops, and then they faint and fall off the toilet. So anyway, I shouldn't be flippant. But, those kind of headaches are a flag. Also, is there something going on up in that brain that's affecting the pressure? Do you have chronic low pressure? Do you have high pressure? Needs to be evaluated. I can't tell that looking at you. Let's see. So rapid onset. I'm going to take that just by category. So rapid onset, what are we worried about? Arterial dissection, like these vertebral arteries. I knew a guy that dissected, and dissection means that there's damage to the wall of the artery. It's not like it dissects and it's cut right in half, like, if you'd stabbed it with a knife. It's that there's a tear in there, and that tear is damaged that can cause clot to form in that area that can block flow, or worse yet, it'll send it upstream and block flow elsewhere. So rapid sudden movements of the neck can do that. That's why I'm like, be very careful when anybody does anything to your neck. There should never be rapid movements. And if you're going to do traction, it should be gentle and within reason, no pain. I knew a guy, he was leaning backwards like this and cleaning out his washer, his clothes washer, dissected his vertebral artery. And, sometimes you can have spontaneous dissection too. And people who have underlying like collagen disorders, some of these autoimmune things, they can spontaneously dissect. But, the bottom line is you end up with a stroke on top of everything else usually. And there is headache with it. There's pain in the neck and then there's pain in the head. So, you come into me with a new headache that just started like that, and especially if you have any neurodeficits, it's my job to think of the worst case scenario and rule that out, or and find it quickly if that's what the problem is. So a TIA, a transient ischemic attack. I will tell you though that most strokes are ischemic, right? That means lack of blood flow. The problem is caused by lack of blood flow. Headache is not a hallmark of ischemic stroke. It doesn't mean it never happens, but as a rule, it's not a hallmark of ischemic stroke. So I'm going to be thinking about other issues. Doesn't mean that's not on my list, but it's probably not number one on my list. Subarachnoid hemorrhage, sudden onset of the worst headache of my life, this thunderclap headache. I want to make sure you didn't have an aneurysm that ruptured, because that is life-threatening, or it can be. Venous sinus thrombosis, it's just what it sounds like. You can have a deep vein clot in your brain too. So who's the most likely person to have that? It's usually a young female on combined OCPs or some kind of combined contraception that has both estrogen and progesterone. You don't really see things like that on like Norplant and Mirenas and stuff. It's usually going to. I actually have a niece who is a Marine Corps officer and was using a Nuva ring, which is an estrogen progesterone combination. And we use way less estrogen nowadays than back in the 60s and 70s. But here she was, 25, 26 years old, had a stroke because a venous sinus thrombosis is considered a stroke. And because veins are thin-walled and weak, if you have a clot in that vein, it can kind of push over into the brain tissue itself and cause some local swelling and bleeding even as well. So, she's fine, she's a major, she's in Germany now, but it was a little exciting, the kind that you don't want. So usually it's young females on this, but it doesn't mean those are the only people it can happen to. What if you have somebody who has cancer? They are prone to forming clots anyway. That's somebody I would want to rule out. You come to me with a new headache, then I'm going to make sure, and you have those kind of risk factors, and I'm going to look at your arteries and I'm going to check your veins, because I'm going to make sure you don't have a clot up in those two. And those are people who are going to be anticoagulated, right? You're going to have to put them on blood thinners of some kind. Hypoglycemic. Yes, so the rule of thumb in stroke is, don't tell me they're having a stroke until you check their blood sugar. If their blood sugar is 42, let's fix that, and then I can get a good neuro exam. So, you do want to bear that in mind, particularly in our population that takes insulin. And low blood sugar, what does it do? It gives you headaches, makes you shaky, and it definitely can give you neurologic symptoms. Seizure. Headache is very common after seizure. Many people who have epilepsy will tell you that after their seizure is over, they're exhausted and they have terrible headaches. So what do we do with these? You're going to do a CT head as your first thing you're going to do, because that will tell you whether there's bleeding in there or not. That's the main reason for doing that CT. Without contrast, and the reason for that, if anybody's wondering, is the contrast looks just like blood. So if they actually have blood up there and you gave them contrast, you can't tell the difference. So MRI of the brain, if the CT is negative and they still have symptoms, that we can't explain in some other way, MRI is the next best tool, because that's the magic machine that helps you really look at the brain itself, look at the structures of the brain in detail, which you don't get, because CT is a wonderful tool, but it's a fancy x-ray. So, they do different things and we use them differently. We will do some kind of vessel imaging. That can be a CT angiogram, that can be an MR angiogram. An angiogram just means blood vessels. So these are studies where we look at the arteries usually, but we can look at veins. And we can do ultrasound too. You can do carotid ultrasound as well. Lumbar puncture. So if I'm worried about somebody who maybe has low pressure or high pressure in their brain or spinal cord, or particularly the brain, what I do is go very low, below the level of the spinal cord, because it is, the spinal cord comes down and ends in something called the conus medullaris, and that is about T12, so it's the lower end of the thoracic spine, and after that, you have the horsetail, the cauda equina, and that's actually all peripheral nerve at that point. So when we do a lumbar puncture, just like when they do an epidural for anesthesia, like for pregnant ladies or whatever, we're going below the actual cord. We don't want the cord, we just want some of the juice. So you go in that area, small needle, you get what we can do though is there's a manometer, a tool that measures pressure. Before you ever take any spinal fluid, as soon as you get access, you plunk that little manometer on there and it'll tell you what the pressure is within the system. And so that's a very good diagnostic tool. And it also, if you're suspicious of a bleed, but you didn't really see anything on your initial imaging, you can test that fluid, and if they've had, like, for example, maybe they're not bleeding now, but they had one before, it'll show up in there. So that is actually one of the tools. We don't do it as much anymore, but that was one of the ways we used to look for subarachnoid hemorrhage. And then EEG. So if you think somebody's having seizures, you're going to do a brainwave test. Now, they're not as easy to read as ECGs, because your heart's a big muscle, right? And it's pumping in there and it's generating lots of signal. Well, your brain is jello of different densities floating in water surrounded by a scalp and a skull, or a skull and a scalp. So that's you only ever want somebody who does that all the time reading those things, because they're not the easiest thing to interpret, but it can show you structural abnormalities. If somebody's ever had intracranial surgery, they have what's called a skull defect. They had to take the flap off, put it back on. That will never read normally because the electricity passes over it differently. If they have tumor, if they have scar tissue in the brain itself, all that's going to show up differently on an EEG. There are actually discharges that are epileptiform, is what we call them. That's a very technical term for you have abnormal discharges in your brain that look like the kind of discharges that we see with seizure. You're not having a seizure at this moment, but you have this abnormality in there in this spot that, we're very suspicious that you're somebody who could have seizures. Anyway, so that's what the EEG is for, and of course, check the blood sugar. So the thunderclap headache, it's a little bit of an overlap with the sudden onset, because the same issue's there. You come out with a severe headache out of nowhere, I wanted to get checked out, because even migraineurs, they don't get severe headaches out of nowhere. So that should get looked at. Hemorrhagic stroke we talked about. Hemorrhagic is just bleeding. But remember, you can have a subarachnoid hemorrhage, which is aneurysm ruptured. And that is one of the coverings of the brain. There's, you have the meninges and there's the subarachnoid space is really where it happens. But you can have subdural bleeds. So it involves the dura, that's the covering of the brain, and it's usually shearing of the bridging vessels, so the veins that connect to that inner wall of the skull. That's often what shears off in a subdural, so it's like a slow leak. But you can have an epidural bleed, which is arterial, which, is a whole different category of dangerous. I think, who was the actress that died of that? Was it Vanessa Redgrave? Liam Neeson's wife. That's what she had, was an epidural, and probably Sonny Bono for that matter. So those are, emergent. You're going to end up, you got to go to surgery. You've got to, a neurosurgeon has to manage that. And then you can have intraparenchymal hemorrhage, which is a fancy way of saying it's in the brain tissue itself. And those are usually hypertensive. People's blood pressure is 220 or whatever, and they just blow a little gasket in the brain tissue itself. And those often happen deep in the brain, like in places like the basal ganglia and stuff. Unfortunately, that can also happen in the brainstem, and that's pretty catastrophic because that's high rent territory. RCVS, so it stands for this reversible cerebral vasoconstriction syndrome. And think of it like vasospasm, so it's symptoms that are caused by the blood vessel clamping down, reduced blood flow, but they don't usually end up with permanent damage. It will resolve itself. And it's another one of those things that we're not entirely sure, like, what was the trigger for this. Most commonly seen, like, in postpartum women, or, and this is why we're always like, all right, are you on any kind of birth control, and which kind? The changing the OCP, so sometimes they don't tolerate it well, they have side effects or whatever, so they change it up. But I'm talking specifically about the combined ones that have the estrogen in it, because it's not usually a problem with progestin-only things. And they also have an underlying history of migraine most of the time. I personally don't see a lot or treat a lot resected. How do we assess for any of these things? You do a CTA of the head and neck, and that's really the gold standard. You could do an MRA for somebody who has bad kidneys and can't take the contrast, but really you need a CTA. If they're a dialysis patient, we might pre-medicate them and still do the CTA because we dialyze out the contrast. Alrighty, but these are deep things, so you're not going to see them by doing an ultrasound. Uh-oh. Neck pain with or without fever, we're going to worry about meningitis, right? And meningitis, how do you evaluate that? You do a lumbar puncture, and you're looking for infection. So I'm going to be looking at how many white cells are in there. Red cells I don't worry about too much because sometimes you'll just hit a little vessel or something going in, but I want to know what the white cells are, what's the protein look like, what's the sugar look like, because that can give us an idea of whether we're looking at a bacterial problem or a viral problem, for example. And if you get to choose in life and you get meningitis, pick viral. Let's get better outcomes. You're going to look at labs. We look at things like SED rate, CRP, which are non-specific markers, but that can indicate some kind of autoimmune process. Giant cell arteritis or temporal arteritis, these are vasculitides. So this is vascular inflammation and irritation of the blood vessels themselves. And they can often be thin-walled during these things too. But it is an autoimmune process. So if you have headache and you're over 50, we're going to be asking you things like, does it hurt right up here? Does it hurt when I touch? I'm going to be palpating, actually looking for crepitus. You can sort of palpate and they feel funny. Do you have jaw claudication? In other words, do you have pain here, like this chewing and things like that? Is that a problem? And not necessarily TMJ kind of stuff, which, sometimes people will tell you that, and that's really what they have. But what we're thinking about is, do you have this going on? It's sort of like having a rheumatoid arthritis or something, because the treatment is prednisone. And usually you're going to be on it a minimum of a year, often up to 2 years. So it's long-term management with steroids if you have giant cell arteritis or temporal arteritis, which is, temporal arteritis is just a subset of giant cell arteritis. And the diagnosis is actually a biopsy. They have to go in and take a little piece of the temporal artery and look at it under a microscope. So, and it's one of those crossover things. We'll often do the diagnosis, do the workup, and then the management is rheumatology. We do MRIs of the brain, MRAs of the head and neck, and focal neurologic symptoms, just to back up again, is something like I have, numbness, tingling, weakness on one side of the body, in my face, I talk funny, I lost vision in one eye. All of those things are potentially stroke symptoms. So even if you have headache, I'm not going to say you have a complicated migraine or a hemiplegic migraine, which is just what it sounds like. One half of your body just doesn't work. It's just paralyzed. I am not going to tell you you have that until I check for stroke. Now, if you've been worked up and you didn't have stroke and you come back with the same headache with the same symptoms, then I am more comfortable saying, okay, this is your headache and we need to just get it under control. But the first time you ever show up with that, I don't care if you're 20 or 80, that needs to be thoroughly vetted to make sure it isn't something more serious underlying it. Nobody should ever make the assumption that's just your headache if that's the first time that's ever happened to you. And even people who have migraines, if you show up and you have a different headache than usual, if your headache is changed in character, that probably should get worked up too. I mean, everybody who has headaches should get at least one set of imaging. You don't have to do it every time you have a headache, but you should at least at some point have had an MRI, at least a CT, if not an MRI, because things do get found. If you have vision issues, you should probably have an ophthalmology exam, because if you have, for example, papilledema, where we can see swelling in the back on the optic disc where the nerve exits out, then you maybe are a person who has intracranial hypertension. So, like what we used to call pseudotumor cerebri. That can be managed medically. If it doesn't respond, then people end up with shunts. But again, it's something you have to recognize because people can lose their vision from it. So that's another population of headache that will end up getting a lumbar puncture, because we need to know what the pressures are. That's how you track it. And then they get follow-up with ophthalmology routinely to look at the eyes. Okay, we talked about meningitis. So this is where that age 50, vasculitides, intracranial tumors, primary or metastatic, and those tend to be up in the hemispheres. As a rule of thumb, children get the ones down in the back and below the brain, and adults tend to get ones up in the hemispheres. So that can be anything from like glioblastoma multiforme or any of the gliomas, which are primary brain cancers. Often what we're seeing are metastatic cancers. The most common ones, breast, lung, and renal cell carcinoma. Things like CNS lymphoma do exist, not common, but and the way you're going to do that is look at the imaging, and you have to get contrast. If you're worried about infection or tumor or something like that, you need to get the contrast sequences too. And these people will probably get lumbar punctures too, and we send it off for a slew of stuff. Again, check it, they're just a slew of labs and things we do. So the bottom thing is you're going to give us blood, we're going to get spinal fluid, and we're going to image you. That's it, pretty much in a nutshell. And then if you have horrendous high blood pressure that's causing your symptoms, then we need to treat that too. Because, and I didn't really emphasize that, but when these people who have uncontrolled hypertension, it's called a silent killer for a reason. They may have had uncontrolled hypertension for years and never had any problems. If you have headaches, I'm happy, because then you come in and, because you're like, every day I wake up with a headache, it's back here. And finally you seek care, and then we figure out that you have this high blood pressure that needs to be managed. Often people really have it for years and years and paid no attention, may not have seen a doctor and didn't have any symptoms, and the next thing you know, they have heart failure and they've had a stroke, and or even stroke can be bleed or ischemic, so not something to take lightly. It's one of our, the single biggest risk factor for having a stroke actually is high blood pressure. No matter where you live in the world, no matter what color you are, no matter what food you eat, it's high blood pressure. That is kind of the unifying thing for stroke risk factors. So talked about the positional changes. Yeah, I think we've talked about all this stuff. If you do have new or worsening headaches, the other thing that we do look at, and this is where your history comes in, is, all right, what medications are you on? What are you taking and why? Do you have high blood pressure? Do you have something up in your head? This is why everybody should get at least one-time imaging, because we need to look at your brain. Medication side effects. Are you on a new medication? And is it one that might predispose you to having headaches? Now, counting pills, keeping a headache diary, medication taper, monitoring. When I say counting pills, is like, how much of that are you actually taking? You know what I mean? Like, so, oh, I only take it once in a while. All right, I want you to actually record when you take that medicine, because that every once in a while could turn out to be, you know, like every other day, so which changes things, right? So, and we talked about that too. We do check blood because, you know, maybe you have an electrolyte imbalance. If it's that straightforward, great, let's focus on that. But then of course it's never quite that simple, because it's like, okay, if you have an electrolyte imbalance, why do you have an electrolyte imbalance? You know, are you dehydrated and your potassium's low because you're on a diuretic? Oh golly, I way over talked, didn't I? All right, let's go. Questions, anybody? I'm pretty much done, I think.
You covered everything. Really? Did you have something?
So Fran, I want to thank you for being here today. I'm going to go ahead and we'll sign off. That was great. You had so much information to share. I mean, there is a variety of things that we need to know when we're looking at a headache, and you truly showed how much there is, and there's a difference depending on what type of headache you have. So thank you so much for being here, and we will see everyone again next time.
Thanks for sticking around.